All right, well, I guess at the very least, we can start with introductions while some additional folks are joining, because I think they mostly know us already. So good afternoon, everyone. My name is Michelle Probert. I'm the director for Main Care, and thanks for joining us this afternoon. Just in the interest of time, I think we will, well, let's see, I'll introduce folks, or I'll have folks introduce themselves who are going to speak. And so let's start off with David, if you want to introduce yourself and the rate setting team.
Sure, thanks, Michelle. And hello, everyone. I am David Jorgensen, Director of Data Analytics and Rate Setting. With me today with the rate setting team is Peter Kraut, the Manager of Rate Setting, Mandy Lee, our rate setting coordinator, Jessica Levesque, our project manager for this hospital rate determination. And I believe that is all from rate setting who will be speaking today.
Great, thanks, David. And Jenny, could you introduce yourself and policy and Dean's special role as well?
Sure. Hi, everyone. I'm Jenny Patterson. I am the Director of Policy for the Office of Main Care Services. And from my team today, we have Kristen Merrill, who is our State Plan Manager, and Kathy Coolidge, who is the policy writer for the hospital section of policy. We have special guest, Dean Bugay, formerly of my team as the Children's and Behavioral Health Policy Manager, and Dean is now with the Office of Child and Family Services in a new role as Associate Director for Children's and Behavioral Health. And pardon me if I mangled your title, Dean, hopefully I got it correct. So we're happy to be here.
Great, thanks, Jenny and David. And we also have folks here, other folks from Main Care, as well as from the Commissioner's Office and from the Office of Behavioral Health. I think also from the Office of Child and Family Services. I would ask that if folks could introduce themselves in the chat, if they haven't already been introduced, that would be great. And I will also ask that folks who do not work for the state but are here as guests, if you could introduce yourselves in the chat as well, then that will help let us know who is here and who may not be here. And let's see, I would also like Mark from Burns & Associates to introduce himself.
Good afternoon, I'm Mark Podrozic from the Burns & Associates Division at Health Management Associates. We're a unit within the larger HMA healthcare consulting organization, and our specialization is working with state Medicaid agencies on a variety of projects, including rate setting studies and more particularly hospital reimbursement. It's nice to be here with you today.
Thanks, Mark. All right, Mandy, so now we can put up the slides if you don't mind sharing. And again, don't be shy to introduce yourself in the chat because it would be very helpful for us to know what hospitals are represented here today. All right, next slide, Amanda, to the agenda. There we go. All right, so just to give folks an idea of the agenda for today's meeting, first, I'll give a little bit of a very high-level overview of why we're here today, and then we'll talk in a bit more detail about the general rate determination process that the Office of Main Care now follows for whenever we are determining what rates we should pay for a service. Then we will be talking specifically about the draft methodology that we are proposing to utilize for distinct psychiatric and distinct substance use disorder treatment units. We'll have a bit of a discussion about who are the distinct units and also how reimbursement data that we track on our side obviously compares to how you all are tracking things on your side. And then we'll talk about some next steps. So we can go to the next slide, Mandy. All right, so first I'll just say that this work that we have been engaging in and that we are looking for your feedback on today, this has been a priority for the department prior to the passage of Chapter 639, which is the law that just passed that codifies the process as well as priorities and principles for main care's rate setting process. This work was a priority for a couple of different reasons. One is that the department as a whole is very committed to having a strong continuum of care for all behavioral health needs. And we know that especially during the pandemic, the needs for strong care in terms of substance use disorder and serious mental illness and serious emotional disturbance has only been heightened. In addition to the importance of the service, and thank you all for the work that you do, we also know that the standard, quote, standard rates for these services have not been addressed in a long time in an across-the-board manner. They're long overdue for the kind of work that we have been engaged in now. And I think partially because work was so long overdue to do an overall assessment of what should these rates be. In the meantime, there have been a number of provider-specific rates that have gotten legislated over time to kind of fill that void. And provider-specific rates, while they certainly can be very helpful to the specific provider, do not tend to be so equitable. And are not really transparent, are not data driven in a way that that the state has access to or that other providers have access to. And so we've been clear throughout our main care rate reform process that we want to make sure that we have rate methodologies that are based on data and that are consistent and equitable. And that we can look to and ensure that those rates are adequate and reasonable and sustainable. So those are some of the reasons why we prioritized engaging in this work even before Chapter 639 was passed and before we had formalized what our overall schedule for reassessing rates for services would be within main care. So I'm going to give a couple of spoiler alerts. And so sorry, Mark, that I'm going to take away some of your glory here. But first, I'll just say to set expectations, and this might be a disappointment to some of you, we are not going to give you a level of information today that will enable you to go back and crunch numbers to say, what will these rates mean for us as a hospital or as a system? That is going to be the next step, and we will reconvene when we have that level of information. But in order to get to that next step, and we'll talk about this later in the presentation, we'll need your feedback on identification of these different psych and distinct SUD units, as well as the alignment of our respective understanding of main care reimbursement for these units. So the good news is that we are going from an outdated rate that does not vary based on patient acuity or length of stay. The methodology that we are recommending is per diem, and it is adjusted based on patient diagnoses and other factors. I will also state that barring any significant changes in terms of our understanding of who are the distinct units as well as the associated reimbursement, our intent is to calculate the base rate so that once it's adjusted for these other factors, it does cover 100% of costs. So again, that is the caveat there is that we need confirmation that there aren't going to be significant changes to our understanding of the data as it currently lies. But that is our intent with this process. All right, so with that, next slide, Mandy. I am going to look to Jessica, I think, to talk about our rate determination process in general. Thanks.
Okay, thank you, Michelle. As Michelle had discussed, that Chapter Public Law Chapter 639 was enacted in August of 22. And this establishes a process for the rate determination, which includes things such as stakeholder engagement, public presentation of draft rate models, an opportunity for written comments, DHHS's response to written comments, and revised rate proposals in a formal rulemaking. In this case of Section 45 distinct psych and SUD units, the process will be, we're having today's meeting. Then we will have an opportunity for hospitals to submit any input regarding methodology, definition, identification of all psych or SUD units and any other concerns you may have to us no later than this Friday, December 23rd. Then we'll be having another public presentation of the draft base rates and any adjustments to the methodology the second week in January. We will be getting an exact date soon. Then we will have you'll have a 2-week opportunity for written comments after that January meeting. Then the department will review and have responses to those comments. And we are looking for a target date of April 1st, 2023 as our preferred effective date. And if there's no comments at this point, I would turn it over to Mark from Burns, who could do the presentation of the draft methodology.
Thank you, Jessica. And I think I only have about 3 slides, since hopefully this will be relatively straightforward. Many of you are probably quite familiar with Medicare's payment methodology, but as a reminder to all, the formula there is in blue. And fundamentally, it's a per diem rate multiplied by the relative weight value that the case groups into. And then that is multiplied by a length of stay factor. And this methodology is currently used by CMS for freestanding psychiatric facilities, as well as distinct part units for psychiatric care in acute care hospitals. Next slide, please. So a little bit more about the Medicare method. It's inclusive of all operating and capital costs. You can see that there is a standard base per diem rate of $865.63 right now, but that is adjusted for localities across the country. For wages, 77% about of that $865 is adjusted, and the remaining 23% is not adjusted. Furthermore, the rate could be different by facility and client based upon age, as well as some comorbidities. And so all of those factors get multiplied against the starting point of the $865.63, the local wage adjustment, the age, and the comorbidity. Then all of that is then multiplied times the relative weight of the DRG that the case falls into, and then the length of stay factor. So OMS is proposing for its methodology that using the Medicare methodology in spirit, but not quite all the particulars, and that is that it would be per diem, it would be inclusive of operating and capital costs, although we do have a slight caveat there at the bottom. No local wage adjusters, so it would be the same base rate throughout the state of Maine for OMS. Do not apply the age and comorbidity adjusters. However, OMS is considering instead to potentially have a different starting base per diem for psychiatric cases compared to SUD cases, as well as potentially a different starting base rate for youth and adolescents versus adults. Next slide, please.
And Mark, I would just say that the main factor in our consideration of those differences is really the cost data, and where we see significant differences versus not. So we've seen some patterns currently, but again, need to confirm that our understanding of the data aligns with yours to be able to confirm what we're recommending there.
So that covers the base per diem rate or potential multiple per diem rates. Then when we turn to the second piece of the formula, which is the relative weight, this box here shows you the DRGs of interest in the MS-DRG grouper that are related to either mental health or SUD. And you can see the number in the description. And then the next column is the current OMS relative weight, which everyone recognizes is quite out of date. And we compare that to Medicare's federal fiscal year 2023 relative weights. And with the exception of DRG 886, which parenthetically, we are not seeing a lot of volume in amongst the Medicaid population, the Medicare weights are higher than the current OMS weights. So as part of the payment methodology, OMS is proposing for this particular methodology specifically to pivot to using Medicare's relative weights instead of the current OMS relative weights.
And Mark, just to clarify, and this is in the footnote here, so we recognize with our current distinct unit discharge rates, we are not using weights at all. But we do use them for regular inpatient. But for these rates, when we said, okay, well, we do want to apply DRG weights, do we use what we've been using for the rest of main care inpatient, or do we look to use Medicare's? And given how different Medicare's are now compared to the current OMS rates, we wanted to go with the OMS weights. And I'll just put a second just note out there that our next one of our next big projects for hospitals is looking at the broader inpatient picture and DRGs, because as Mark has noted, and as you all know, those have not been addressed in some time.
Correct. Next slide, please. The third key component to the formula is the length of stay factor. So in Medicare's payment methodology for eligible hospitals under this methodology, you take that per diem rate with all of its adjustments, you multiply it times the relative weight, and then you further multiply it by this factor, where, as you can see, the factor is greater than 1 at the start of the stay. In day number 1, it's effectively 131% of a standard rate, and then it drops to 112% on day 2 and further down, and it goes down to as low as 92% of the average per diem once we get down to day 22, and it's cumulative in nature. That's the third column. So depending upon the number of days that the patient is in the facility, you look across to the far right column, and that would be the factor that will be multiplying by. These are the Medicare factors, and OMS is proposing to adopt Medicare's factors and approach as is, as it's shown here. And of course, it goes beyond the 25th day. If the person's there 100 days, you just keep adding 0.92 every additional day down the line here. I think we're ready for the next slide, and I'm not quite sure who's coming up next, but it's somebody from the OMS team.
Mark, I think I'll actually just pause to see if there are questions. I know you just went through a lot, and I want to make sure that people have an accurate understanding of what you presented.
Sure.
Can I ask, for Medicare, there's an emergency room factor for day 1. Is that being considered?
Not at the moment. Part of in considering all the different widgets, if you will, that Medicare is applying as adjusters, part of the impetus here is administrative simplicity, both on the hospital side and the OMS side. So some of these things like that age and comorbidity did not seem to carry as much weight in the Medicaid population as potentially a youth and adolescent versus adult rate, or a mental health and an SUD per diem. So that was kind of a thought behind which methods of Medicare to use and which to not.
Thank you.
Can I, Jeff Austin with the Hospital Association. My hand hurts from writing so fast. Can you share these slides with us if we have a comment deadline by Friday? That would be really helpful.
Yes, Jessica, do you want to talk about how we'll be sharing slides and recording, et cetera, if we have that? Or someone from Rate Setting?
Yeah. I mean, I can send out the slides. They'll be posted on a website and we can send out that link, but in an effort to get them to them quicker, I could send out the slide presentation and follow up with the website link. That would be the most helpful.
Yeah, and so Jeff, we'll send it to you and David, and then it would be great if you could forward it to the hospitals. Could you do that for us?
We can do that, Peter.
Thank you, David.
Sure, it'd be helpful also to have a list of attendees, so we don't miss anyone.
And to that point, it would be great, about half the people on the call have put in the chat who they are. The half who haven't, it would be great if you could too. Thanks.
Any other questions about the methodology as presented?
I guess the only other thing that I would close out, if there aren't any questions, is as the director stated, that besides whether there's more than one per diem as the starting point is still an open question. And I don't think anyone's proposing to use Medicare's per diem as the starting point. It would be a Medicaid specific per diem or per diems. And part of that is obviously to address the cost coverage intent as well.
And I would flag that as you provide comments, if you have opinions, especially opinions grounded in your own data and experience, if you think, for example, that it does or it doesn't make sense to have different rates for psych units versus SUD units, or if you think it does or doesn't make sense to have different base rates for youth versus adults, that is helpful information to share as well. All right.
This is Gene. I have just a quick question and thought for the group, because I know that there was at least some level of internal conversation around. But in terms of youth versus adult rates, what would be the age that would be the dividing line between youth and adult? Would that be the EPSTT CMS age 21 standard, or looking at a potentially different standard at age 18? And do the folks on the line have any opinion on that question as well?
Thanks, Dean, for bringing that up. And I'll say that internally, from a policy perspective and align with how CMS looks at things, there's an argument where we thought it may make sense to have the breaking point be age 21, but then from a clinical perspective and operational perspective, I don't know whether or not that aligns how the distinct psych units themselves are designed, if you will. So absolutely, if you have opinions on age 18 versus 21, that would be helpful to know. All right, I think we can move on. So as we've already alluded to earlier in the presentation, we recognize that on the state side, we could do some tightening up in our communications to all of you to ensure that we're all getting consistent information about distinct psychiatric and SUD units, as well as number of beds. When we looked internally at information from our audit division versus our Office of Licensing versus main care, not all the information from hospitals or the units were complete or consistent. So we will be looking to improve that. And I will also note that when we were looking at claims payments, we identified some inconsistencies. So as I hope everyone is aware, for both the distinct psych and SUD units, the billing per policy is on a per discharge basis. And we understand that there may be some kind of outlier situations where, for example, if a patient was pregnant and gave birth, then you would expect to see like other billing, for example, beyond that discharge rate. But we saw some more inconsistencies, I think it's fair to say, than we would have anticipated. And so because of that, we are very appreciative of the Hospital Association for reaching out to you to help us confirm, this is our understanding as listed of who we think has distinct units in the state of Maine right now. Is that how you consider yourselves? Are there other distinct units that are not on this list? So that information is good for us to know. Also, we'll touch on this on the next slide as well, but our current definition for distinct psych units involves reporting to Medicare. And so does everyone currently meet that status? Collecting how many beds you have on record, because again, we didn't have completely consistent information on that front for the department. And then we have shared with you through MHA, looking at MaineCare's claims data, specifically around discharge rates. These are the dollar amounts that we see affiliated for these different hospitals that we would assume are related to the distinct unit. But if your hospital doesn't agree with those numbers, then that would seem to indicate that there's a disconnect in how the services are being billed. And so we really want to make sure that when we're looking at the underlying data to calculate what these rates should be, that we're looking at the right underlying data. And that's why you don't see numbers in terms of what a base rate would be today, is that we feel hopeful that our data is directionally correct, but we'd like confirmation of that before we start sharing numbers.
Hey, Michelle, it's David. As I mentioned to you late last week, we have most of the information already collected, not all of it, but and as oftentimes happens, more questions sometimes lead to more questions. So we've been sort of sorting through that over the last couple of days, but we're doing pretty well collecting it and plan on getting it to you in the next day or so.
Awesome. Thank you so much. We really appreciate the work from everybody. All right. Next slide. I know this is text heavy, but Jenny, I think this is you.
Yep, this is my slide. Thanks, everyone. And we thought it would be helpful for folks to take a look at the existing definitions in policy for both distinct psych units and distinct SUD units, because those do exist in Chapter 3, Section 45. And I think, as Michelle had mentioned, kind of some key distinctions is that the distinct psychiatric unit, that definition requires that the unit either be reimbursed as a distinct psychiatric unit as a subprovider on the Medicare cost report, or that it's comprised of beds reserved for use by involuntary commitment under the terms of the contract with DHHS. Whereas the distinct SUD unit has more of a functional definition. So it talks about the types of services that are provided in that unit. But for both, the claim must also be distinguishable as representing discharge from a distinct unit in the MaineCare claims billings system. So those are the key differences. And again, it'll be very helpful to have the input by the end of the week on this issue as we look at how we want to be defining these units. I don't know, Michelle, was there anything else you wanted to flag in these definitions?
I'll just say that I think we've already determined that these could be like simplified or may need to be adjusted. Our intent in that process is not to completely upset the apple cart. We just want to make sure that we're being accurate and clear. And so if you see things in the current definition where you raise your eyebrows and are like, "Ooh, that might be a problem," like that would be good for us to know. So I think that's where I'd keep my comments on that, Jenny.
Great, thank you.
Any questions from folks on this front? Or initial reactions? Okay. Jessica?
Hi, so next steps, as we've talked about, we'll have until this Friday to submit any written comments to us. I will provide the PowerPoint as well as my email address when I send that out to Mark and Jeff. My email address is at the bottom of this slide. After that, we will have a public presentation for the draft rates on any adjustments to the rate methodology, and that will be the second week of January. We will announce a date at a later time. After that meeting, we will have 2 weeks for written comments. Then the department will review and have responses to the comments. And again, we are targeting the date of April 1st, 2023 as the preferred effective date. I'll turn it back to Michelle.
Thanks, Jessica. So I think that is it for our agenda. And so folks have additional questions or comments at this time, we're happy to take them.
This is Jeff. I'm fairly ignorant on some of this stuff. How do you handle inflation annual adjustments, regardless of what your base methodology is? How does annual year-to-year changes happen?
I think that is an excellent question, and we've talked about it a little bit, but I think that we will have a better answer for that when we reconvene in terms of a proposal for what it will look like going forward. I will say, though, that as many of you may be aware or may not, as part of the Chapter 639, we do commit to annual updates. And so there will be a regular update. I just can't speak to the mechanics of how we would do that at this time. But I can say that part of what we're trying to prevent is another instance where you could go 10 years without something being updated, which we know has happened in the past. All right. Well, we are feeling very good about this new proposed methodology and think that it will be a great improvement upon the existing methodology. And I hope that you all are sharing, even if cautiously, our optimism with this approach as opposed to the current. So again, we know it's a tight turnaround. We will be having that second opportunity for additional engagement and comment. So this is certainly not your last shot at this by any means. And part of the reason for that time crunch is because we're trying to prioritize getting these out as soon as we can. Many of you are aware that we've been in the midst of rate determination process for all of our community-based as well as outpatient behavioral health rates. And so that has also been a big priority and taken quite a bit of time, but it also does all fit together in terms of continuum of care. So we are looking forward to having a continuum of care that is fully supported by main care rates. So we will be sending out the presentation. This was recorded, so we will also be getting a link up to the recording of the presentation and look forward to receiving the information from you that David referenced, as well as any additional comments by Friday. Thanks very much and have a great afternoon.